Hello, and welcome to the Feeding Pod. This is your host. I'm Bri Miluk, and I am a speech-language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So without further ado, let's get into today's episode. Welcome back to the Feeding Pod. Today I have Dr. Richard Knoll with us, and he is a gastroenterologist who is going to talk all things GI related to pediatric feeding with us. Dr. Knoll, we're so happy to have you here, and I'm going to pass it over to you to give just a quick introduction.
Thanks, Bri. First of all, it's a huge pleasure to be here and talk to you and your audience. I initially found you just flipping through Instagram, seeing what's there and under feeding, and there you were with some pretty witty, funny stuff, but also really good content. And I think I texted you or messaged you that I liked your stuff, and that's how we connected. And here we are. Been in GI for about 20 years now, and GI is a broad field. Some people are doing more like inflammatory bowel disease or liver stuff. I gravitated more towards feeding issues and aerodigestive issues. And that's probably more because of the early training I got. In Cincinnati, I connected with Dr. Colin Rudolph, who has since retired from the field, but he was one of those first people that really understood a lot of things. He understood what speech pathologists bring. He understood what psychologists bring. He understood if you put all these things together, you get some kind of synergy that's necessary to treat some of the more complicated people. And then he ended up moving to Wisconsin, and I ended up going up there also. And I worked with him for about 10 years. And I learned a lot about what speech pathologists do and how we all kind of work in this weird kind of middle area that's kind of sort of medicine, sort of skill acquisition, sort of behavioral. And it was a lot of fun. Great people up there in Wisconsin. It was a big clinic that had outpatient and inpatient feeding. Through Dr. Rudolph, I also got connected with the folks at Feeding Matters, and they've taken it even further with a consensus definition, the ICD code coming, all kinds of great things that they've done. But anyway, it's probably the part of my job I like the most.
Yeah. Awesome. Thank you so much. And I'm so excited and so happy that you reached out to me that day when you were just like, hey, just wanted to let you know, I found your stuff. And of course, I was fangirling that Dr. Richard Knoll reached out to me because I've read probably all your articles. I remember telling my husband, I was like, so this is so cool. I'm just really happy to connect with you because I appreciate everything you do for the field and put out there. And yeah, so happy you're here. Awesome. So to just go ahead and filter over to start out talking about Feeding Matters and that PFD and consensus definition, let's go into that a little bit. We've briefly covered this in previous episodes, but I think it's really important to go into again.
Awesome. Yeah, all these disciplines that basically treat the same or very similar problems each kind of grew up in their own silo. What pediatricians may call weird eating or feeding problems, speech pathologists may call dysphagia, dietitians may call malnutrition, psychologists may refer to it as ARFID, but it's all like the same thing. And basically you have all these different fields coming up with their own language and terms and paradigms for what is essentially the same thing. And when you step back and realize that it's actually all of these things at the same time, and you really need to address all the pieces, especially for the more complicated cases, then it becomes important to have a common language and common terminology where we can slip from the SLP world right into medicine, right into the behavioral world very seamlessly because we're all working on the same thing. Feeding Matters is an advocacy group out of Arizona, and they were started by a group of very concerned moms who didn't feel that they were getting the right resources or the right care for medically complex kids that had feeding problems. Two of those original moms I know quite well, Chris Lynn and Shannon Goldwater. And somehow, I think it was Shannon Goldwater that connected with my boss, Colin Rudolph. And he said, no, let's just see you guys up in Milwaukee and we'll look at everything. And this is after they kind of bounced around the country, not getting the answers that they needed. And through very simple, kind of good multidisciplinary assessments, all these things were figured out. This is a skill issue. This is an anatomic issue. This is a GI issue. This is a nutrition issue. This is behavior. And let's get to work on working on these. And we made some tremendous progress. And Dr. Rudolph struck up a great relationship with them. I think he did a lot of the initial kind of guidance on, you need to connect with this person, you need to invite this person, you're putting a lot of people together. And I always tell them, this group of crazy moms, they've become a fairly sophisticated group that has big league kind of resources, big league impact. They've had some great in-person meetings. I guess they've gone virtual the last couple of years. Next year's going to be virtual. But one of the things they're able to do is to basically fund and organize all the people that were authors in that consensus paper coming together it was like an entire day with a lot of pre-work and post-work. But there's a lot of things that came out of that day that were special. The biggest aspect of the definition that I think is helpful is that it's worded and framed in terms of a disability. Because one of the struggles that we always talked about was, you have these kids that have these obvious issues and needs for G-tube and therapy and so forth, but they're medically sound, they're growing well. And how can I access the same resources that the kid with grade 5 CP is able to access very easily? Where I have very similar needs in some ways. And that's because I think thinking about dysphagia or feeding problems, malnutrition, they're not really written as a disability. So that's the biggest piece that I think the consensus definition brings. And I think it's a great document that came out that talks about the medical, the nutritional, the skill, and the psychosocial dysfunction. And it was all put together with really, qualified representatives from all those disciplines all together. And it's something that would have never happened without Feeding Matters. So that's strictly a Feeding Matters kind of thing. And I think most of us that work with Feeding Matters are very loyal to them. Because the thing that struck me the most about that organization, especially those founding mothers, is that, first of all, they lived it. It's not like they were just in it for some career advancement or anything like that. They're actually living this, and they know what they're talking about because they've been to most of the places around the country that deal with this. And the other thing that was amazing about them, Chris Lynn and Shannon Goldwater, is that they were able to separate being the mom from being the professional advocacy association leader, which is really hard and tricky because there's some things about being the mom that are more emotional that I have a hard time connecting with. And there are some things about feeding disorder that are just very kind of cold and technical that a mom would have a hard time connecting with, but they're able to walk the line very well. And now Jacqueline Peterson's in charge of the association or the organization, and she's doing a terrific job so far. So I think it will continue to grow.
Yeah, that's awesome. I think it's like you said, the work that they are doing there is just so wonderful and so great. And that advocacy and the lobbying that they do is so important. And I think in turn has already benefited so many children, and it's just going to continue to grow and help so many. And something that I really love about Feeding Matters is how much they put emphasis on a multidisciplinary approach, because it is a very rare occasion that I have a child that doesn't also need to be seen by another discipline. It's very rare. And so I think I love that by dividing into those 4 components of the medical, nutritional, the feeding skill, and the psychosocial, it really shows you that not only is there often a lot of overlap and that they coincide together, but that's all the more reason that you need other disciplines involved in the care. Or it really won't be successful in
Yep.
creating progress and change. Yep, I love that. If you don't mind, will you do a brief overview of those 4 domains for everyone in case they haven't listened to the previous episode?
Yeah. So, the definition, the consensus definition is this disturbance in intake of nutrients inappropriate for age, lasting at least 2 weeks and associated with one or more of the following. So the first is medical dysfunction. So that could be any type of cardiorespiratory problem, sequela of aspiration, GI issues like eosinophilic esophagitis, whatever, any of that could play a role. Nutritional dysfunction would be any degree of malnutrition. By that meaning either specific nutrient deficiency or just poor growth, but also a reliance on supplemental enteral feeds. So if you are growing beautifully well with perfect nutrition, but it's all coming from formula at age 2, there's a problem. Feeding skill dysfunction is the third realm here, the third parameter. That's anybody that may require any degree of textural modification or specialized equipment or modified feeding strategies. And then the last domain is the psychosocial or behavioral domain. And that's if you have avoidance by the child, any kind of caregiver dysfunction where you have parents that are just burnt out, any kind of disrupted social function within the feeding context, disrupted caregiver-child relationships that make advancing skills more difficult. And like you said, all of these domains play a role, especially as you get to the more and more complex kids coming out of NICUs, coming out of congenital heart programs. They need all 4 domains usually.
Yeah, absolutely. And I think this is also an important point that I make is a lot of times I say it's not behavioral because that's typically not the only thing going on. While there are psychosocial components that play a role, oftentimes you'll have children who have a history of the medical side of stuff or nutritional things that were underlying and going on. And until those are resolved, it's really hard to target that psychosocial component. And yeah, I just love that there's the 4 domains because it recognizes that, yes, this is something like there can be behavioral components. However, we have to figure out the underlying reason why we're seeing those first. And like you said, it could be just the caregivers are burnt out and there's so much stuff going on and they're burnt out. It's hard to implement the strategies they're being told.
Yeah.
So in terms of those 4 domains, I would think majority of where your role comes into play is the medical and nutritional.
Yeah, obviously the medical one, but nutrition, we definitely dabble in that, acknowledging that dietitians know a whole lot more than I do. But, nutrition is a part of GI training and, it's something we always pay close attention to. It's just very closely intertwined with the medical thing. So, the things that I care about the most when I'm seeing somebody for the first time is first and foremost, are you growing? Growth is number 1. Without growth, there's no development. Without development, there's no progress in anything. So growth is number 1. So we always look at, are you gaining weight appropriately, which would be your weight velocity, but does your weight also match up with your height, which would be your body mass, or in a very young child, your weight to length percentile. Always think about micronutrient deficiencies, especially folks who are on very limited diets or maybe older autistic kids that go on food jags or whatever. There's always a potential for missing out on vitamin D, iron, you name it. And part of that care may include a variety of formulas. So you have to be knowledgeable of different formulas and what role they play, and also work with folks like yourself on any textural modifications that have to be made to the diet to maximize efficiency, safety, and that kind of thing.
Yeah. I have a quick question because I know this is one that is brought up a lot in our field. And so in terms of healthy growth. Okay. So we always think about the growth chart, and it is a lot of times emphasized and causes a lot of stress on families in terms of like, my child's not at the 50th percentile, they're at the 7th percentile. But as you mentioned, you're looking more so that it's just matching their healthy growth. Can you just speak to that a little bit more? And I guess, what are some things you look for in terms of, okay, this is signaling we're not growing at the rate we need to be versus maybe the child's just lower on the size chart?
Basically, the 2 things I care about are weight velocity and body mass. So weight velocity, we're just figuring out in grams, how much weight did you gain over the last 2 months? If you gained, let's say 300 grams, so 300 grams divided by 60 would be about 5 grams a day. That's like a normal weight velocity for let's say like an older toddler. And that's something that tells me, okay, we have issues, but we're gaining weight at a normal rate. Now that's just how fast are you gaining weight? The next part is the body mass. So their body mass is a ratio of your weight to your height. So if your body mass, your percentile of BMI, or your weight for length percentile is at the 50th percentile, that means that your height absolutely matches your weight. You are absolutely proportional. But we have this range that goes from about the 3rd to the 97th percentile, which would be normal.
Yep.
And then beyond that, you're either underweight or overweight. So if you have a healthy weight velocity, let's say you're putting on, 10 grams a day as a 2-year-old, but you are underweight because you're way taller than you're heavy, then yeah, you need more calories. And I always tell parents, there's not a specific reason why I can tell you that you need more calories for you specifically, but I can tell you that in general, you are straying from the mainstream, from the herd, and you may be at risk for, obvious nutritional consequences, but maybe for some developmental consequences, either, physical or cognitive. Don't know. We just know that you have strayed far beyond the herd, and we need to get you back in. Conversely, if somebody looks perfectly proportional, but their weight velocity is like 1 gram a day, that means that they're actually sliding down, and you just happen to catch them at a point where they look proportional, but they used to be heavier and they're actually losing weight. So really, those are the 2 things that I look at first. And then we start looking at what are you actually eating?
And you go from there. Yeah, no, that's super helpful, because I think understanding it from the physician's standpoint of, okay, what are you looking for? And so that way, when we have those caregivers that come in and they're like, we're worried about weight, what's going on, or this or that, and just making sure that we understand that.
And there's like some simple analogies that when an endocrinologist I train with, he always talked about, some people are Great Danes, some people are Corgis. If you're a Corgi, I can't make you a Great Dane, but I have to make sure you're a healthy Corgi. So, he was kind of like that.
Makes sense. But, genetics definitely play a bit of a role in it. But you said, seeing that progression, seeing the consistent growth, and that if you were a child who was always in the 90th percentile and all of a sudden you drop to the 40th, that's going to tell us for some reason we're dropping.
Absolutely. Something's going on.
Yeah. Okay. Awesome. Thank you. All right. Moving into, was there anything else about nutrition?
No, I think that's probably enough. And then the medical stuff, when I'm seeing somebody with feeding issues, I'm thinking about the main aerodigestive issues. So going back to like aerodigestive disorders. So the first thing I'm thinking of is, are you growing? Which goes back to nutrition. And if you're not growing, why? The second question is, any problems with upper GI tract kind of stuff. So that would be reflux, vomiting, nausea, pukiness, volume intolerance, all those things. And then the third category would be more related to dysphagia and aspiration and your overall pulmonary health. So those are the 3 things I'm thinking about at the same time. On top of that, there's a couple of things that we often dabble in. One of them is constipation, because kids who are constipated are going to get cramps whenever they feed, which is a demotivator or a negative experience. And then the other thing is, do we need to kind of augment appetite? And we have medications like cyproheptadine that we can always play with. But those are that's probably the bulk of what I'm thinking about when I'm seeing somebody new with a feeding disorder, and whatever other medical things they may have that they come with. But that's the bulk of what I'm thinking about.
Okay. Yeah, that makes sense. So going in through from the medical standpoint, now you mentioned like aerodigestive issues. So when you're moving through with that, what are you thinking about in terms of questions you're going to be asking yourself, and how that might move forward with how you're going to support management of what's going on?
Yeah, first and foremost, are you growing? If you are not growing, I was always taught, and I now teach, there's only 5 categories of why somebody does not grow. Number 1 is not enough calories, and that's the most common thing. And that could be for thousands of different reasons, from inadequate formula preparation. Somebody thought somebody else was feeding the baby, but that's what the other person thought, whatever it might be. Category 2 would be problems with caloric retention, meaning vomiting, or else, inadequate oral skills where something's not retained and spills out and doesn't count. Categories 3 and 4 are similar but different. Category 3 is problems with digestion, where you don't have the enzymes to digest the food. Category 4 would be problems with absorption, where you have some injury to the intestines where you're not absorbing the calories the way you should be. And those 2 present the same way. They're going to present with like bloating, diarrhea, just not gaining weight. And then the 5th category is something else is going on that's competing for calories. And these are big things, not little things. Everybody says, well, he's super active and runs a lot. He's supposed to.
Yeah.
This is not it. What we're looking for is bad problems with hypertonicity. We're looking for seizures, bad respiratory illnesses where you're breathing like 50 times a minute. That kind of stuff just burns a lot of calories.
Yeah. That'd be like potentially cardiac.
Yeah,
conditions as
cardiac,
well.
when you're kind of hypoxic and running with less oxygen in your bloodstream, that's going to just burn more calories. Different types of cardiac lesions where you're just recycling blood between the heart and lungs, that's going to burn up a lot of calories. So in asking questions, I'm asking, first of all, take us through what you're eating. Our dietitian does a way better job at getting that information, but I always dabble in it a little bit. And then I'm asking, is there any vomiting? What's going on with bowel movements? How often? Have you been sick? Are you otherwise healthy? That's what leads me towards deciding what's there or not there. Obviously, we're not making progress with any of that stuff that can lead you to tube feeding, whether it's nasogastric tube feeding or gastrostomy feeding, because you got to be gaining weight, you got to be growing. The second thing is the vomiting, reflux, upper GI tract kind of stuff. You want to see, is this just a normal infantile pattern of reflux? All infants reflux to some extent. It's just part of anatomy. When we're born, we're completely scrunched and don't have any anti-reflux mechanisms. But as we get longer, upright, and transition to some solids, by 10 to 12 months, most of this has resolved in the normal infant. So I want to know, what is the pattern of vomiting or reflux? If it peaked like at 4 months and you're otherwise fine and gaining weight, it's just not that concerned. If it's something that was fine and all of a sudden kind of developed at 8 months of age, that's weird. That's not the normal pattern of infantile reflux. And then reviewing what's been done about it. Have they been on any medications for motility? Almost 100% of these kids have been on acid medications that don't do anything for this. Literally, they do zero for this. Yep. But almost all the kids have been on acid medications to some extent. I want to see what kind of studies they've had, whether it's an upper GI series to look at anatomy. Very few infants get scoped for this kind of stuff, but some have. Have they been scoped? Is there any other tests that they've had? And then obviously problems with controlling reflux and that kind of thing. That's a second road that can lead you to tube feeding, because you can do very slow feeds with a tube that probably are better tolerated by some of the sicker folks that can't do a big meal all at once. And then the third thing we're thinking of aerodigestive is dysphagia or sequela of aspiration. And that's where obviously the speech, the clinical exam is very important. The video fluoroscopic swallow, if it's done, is very important. Sometimes ENT obviously gets involved, whether it's through fees or through a microlaryngoscopy, bronchoscopy in the OR. And that kind of helps us towards making appropriate feeding interventions, whether texture, whether positioning is involved, whether the pace of the feeding, faster, slower, looking at things like stamina and fatigue. And as long as we're maintaining happy lungs, we just keep on going. But if we have somebody whose lungs are all of a sudden unhappy, even though presumably from aspiration, then yeah, we back off. But we generally don't back off to zero. We might back off to just taste flavored water at the very least. We back off to something that continues to have some exposure and experience, but doesn't completely put them at risk. And obviously, these kind of problems with lungs also can lead you to tube feeding. So all these roads can lead to tube feeding on the one end, but then hopefully at the back end, after a bunch of therapy and growth and medical care, they're leading away from tube feeding.
Yeah. And I always like to think of it, especially if I have a child that maybe doesn't have tube feedings right now, but can tell we're on our way, is that it's a great tool. And that's what it is. It's a tool so that your child is nourished and can grow and develop so that they can be able to cognitively absorb a new skill and be able to take on those things. And they can learn to efficiently eat by mouth so that they're not just barely hanging on, and that they feel good enough that they can sit up and participate and do all of those things.
Absolutely. And especially if you are more medically complex, you're also going to have a limit to what you can do. And, if your needs are at a 10, but your abilities are at an 8, there's a gap there that we need, because you have to fulfill your needs or else you're not going to grow. So that's where a tube kind of definitely plays a role. Yeah. So we definitely put tubes in, but we also like taking them out. So it's like a tool, just like you said.
Yep, exactly. I also like how you noted that even with caloric supplements, whether you're getting that through the tube or you're getting that orally, that's still a flag that something's going on. If we need a supplement, even if the child's drinking it through their mouth, that still tells us something's going on that is influencing our feeding, because we shouldn't need Pediasure. We shouldn't need those things. And so it really signals also that yeah, it's great. We don't have a tube feed, but again, that's also a tool. We're still supplementing their nutrition.
Yeah, no, absolutely. And that's a big sign of a problem. And similarly, on the behavioral side or the skill side, if you're eating everything you need, but a meal is taking 90 minutes, that's also a sign that there's a problem.
Yep, definitely. So I know you briefly touched on these, but some of the other things in terms of constipation or needing to potentially stimulate the appetite, because these are both things that I see pretty frequently, especially the children that have very limited diet variety, constipation, or they maybe have some food intolerances that may be influencing their digestive system. Or I have children who have decreased sensation. They just don't feel hunger to the same level, or they've been on tube feeds for so long that their hunger fullness cues are just completely off. So if you can just talk a little bit about that side of how you might move forward with management to support those kiddos.
Yeah, constipation is also something that we often think about because it can impact feeding. Whenever you eat, there's signals from your brain going down to your intestines to move everything forward. And if things are not moving the way they should be, that's when folks get cramps. And if you're trying to advance somebody's diet and interest in eating when they're getting abdominal cramps, behaviorally, that's not a great situation and it's probably not going to work too well. So constipation, there is no like normal, how often should an infant or a toddler have bowel movements? There's no like normal. The thing I care about the most that it's not difficult. So if it's like once every other day, once every 3 days, if it's not difficult or not having abdominal pain, I'm not worried. But if it's 3 times a day and every time it's a struggle and they're having like withholding behaviors, then that's going to be a problem. And that's where we kind of work on making it better. We definitely use medications. We use osmotic laxatives. So these are just medications that just deliver more water to the colon. So that would be like Miralax or milk of magnesia. And there's different forms of magnesium hydroxide. There's like chewables now, and there's tablets and liquid. And what these simply do is they simply deliver more water to the colon. So they're basically adding water to stool. You cannot become dependent or addicted to them. There's no concern for that. And we also like them because they're easily titrated to do what you want. The more you give, the more they do. The less you give, the less they do. So we like those a lot. And then stimulant laxatives, senna at times is an herb. Senna does not make bowel movements any easier. It just makes the colon squeeze harder. So in some of the more problematic kids that are maybe not feeling when they need to go or need a more robust reminder that they need to go, giving them a dose of senna at night in the morning is going to result in a stronger contraction in the colon or a bigger feeling that they have to go. But definitely in the kids who are the big problem constipators, we definitely use these. For somebody with feeding disorder where we just want to make sure constipation is not an issue, they probably don't need a stimulant laxative. And then as folks get a little bit older and they're potty trained, then the scheduled toilet sitting becomes a huge part of this. Most of the time, kids who are constipated, it's not necessarily their diet or whatever. It's simply either not wanting to go because they're doing something cool or interesting, or maybe they've been constipated for such a long time that their body's not quite telling them exactly when they need to go. And either way, we address that just by scheduling toilet sitting. So we have them sit on the potty for 5 minutes, preferably after breakfast, lunch, and dinner, with the goal being that they simply try, and usually that makes a huge difference.
Yeah, awesome. Yeah, that's super helpful. And then moving into the augmentation of appetite, what are some of the things you think about with that and what might need to be done?
Yeah, appetite's a big thing because that's the innate driver that you hope this child would have to make progress. You mentioned the slow overnight tube feeding. Certainly that's going to prevent developing of normal appetite. You're not going to have the normal hunger and satiety cycles. So that's definitely going to make a difference. So as soon as possible, we do like to get away from nighttime tube feeding. And if folks are more like toddler age, they're going to have 3 meals and 2 snacks, whatever is by tube, whatever orally, but we maintain the same structure. If that is not sufficient, then we definitely work on the behavioral side. There are some behavioral determinants of appetite, which the most important thing is eliminating grazing. Kids who are grazing are eating enough to not be hungry, but not eating enough to gain weight. And that kind of affects the meals. And if that's not sufficient by structuring things without grazing, then that's where medications play a role. Cyproheptadine is something we like a lot. It's a very safe medication. It's been around for a long time. It's an antihistamine very similar to Benadryl, but it has some additional anti-serotonin side effects, which do a lot of different things, but they're mostly good things. For example, it antagonizes or blocks the serotonin 3 receptor. That's the Zofran receptor. So it has a little bit of the Zofran anti-nausea effect. So we sometimes use it for unexplained vomiting, but it also blocks the serotonin 2C receptors, which are in the appetite center in the brain. And when you block those, it makes you hungry. So when we use cyproheptadine, we generally use it twice a day. People do all kinds of different things with it. I was taught and still do cycle it because I think that appetite boosting side effect is not always long lasting in people. And if you just leave them on cyproheptadine for a while, after a few weeks, it basically goes away and you're left with Benadryl that you don't need.
Yeah.
So when I have folks for appetite stimulation on cyproheptadine, I basically give it twice a day, but I cycle it 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off. Or depending on what's going on, we might do some other variation. I have patients that do 3 days on and 2 off. Whatever, it seems to work for them. There's not a lot of science to this part, but it does seem to work, and more importantly, it doesn't hurt.
Yeah. I appreciate that you mentioned like a lot of what you're doing initially is focusing on what's the mealtime routine look like? What does the tube feed schedule look like? Because I find in my practice that oftentimes that's all that's needed, that we just needed a change in schedule. We have to eliminate grazing and that's going to support appetite. But there are those few kids that just still need a little more support after that. We've done that. We've established we're still not interested or showing even hunger cues at all. And then that's when I've seen great success with the medication as well. And like you said, it's something hopefully we're not going to need forever, but it is something that for some of these kids just like really gets them started, gets them on that routine. And a lot of times I find that then once they're on that routine, their body has adjusted well.
There's another medication out there that I basically have never used, but it's out there, something called Megestrol or Megace. It's a progesterone derivative that's a massive appetite stimulant. It's used with a lot of adult cancer where their appetite just goes away. There's a couple of studies out there that have looked at inpatient protocols that have like a specific certain week period where they use Megestrol, and that seemed to make a big difference. But it's certainly not a medication that I would feel happy giving to somebody longer term. Let's just try it this way or that way. It's something that has a role, but it's a very specific kind of almost researchy or intensive program kind of role.
Gotcha. Makes sense. Awesome. All right. So now that we have that background information, understand the thought process, where you're coming from with evaluating these patients as well as management of what you see, let's kind of go into some case studies of things you've experienced, what was seen, and how you went about it.
Okay. I thought we could highlight a lot of these topics through a couple of cases and kind of made up a couple of them. They're technically made up, but they're based on basically very real cases.
That's all my cases.
But we can say that they're made up. So, the first one we can talk about is like a 17-month-old with feeding problems and vomiting and delayed advancement of the diet that comes to see me in clinic. I'm getting some history and find out that they were born at term, initially breastfed, transitioned to formula at 4 months of age, had the expected normal pattern of reflux that kind of peaked around 3 to 4 months and then got better. Smooth solids came in around 6 months of age. Everything seemed to be okay. But then it got tricky where they were having a hard time advancing beyond smooth solids. And then around 8 months of age, all of a sudden started refusing things and started vomiting. And those things started compounding each other. They're able to transition to formula at 12 months of age. And now they're 17 months and I'm meeting them for the first time. So I meet them and I note that they're growing well, gaining about 8 grams a day. And I said their weight for length is the 65th percentile. So the weight's coming on the right way and they look proportional. So that's probably okay. Drinking 36 ounces of whole milk by cup, feeding purees 3 times daily. So definitely not age appropriate. So that's something that already qualifies as having a pediatric feeding disorder. Gagging, choking, refusals with any chewable solid, that's already a problem. Vomiting with textures, if happens to accept, will chew, swallow, and then spit it out or vomit. But otherwise, unremarkable development. So this is somebody who's like walking, making their way upstairs, language is coming on, lights are on in somebody's home. And it's just a weird pattern of vomiting that doesn't seem to follow the normal infant vomiting. Their physician kind of put them on Pepcid, as they're 100% going to, and suspects that they may need therapy, but think that they'll likely grow out of it, which we hear all the time. And they made a referral for speech evaluation for feeding therapy, but not yet scheduled. And now I'm meeting them.
Okay. So it's so funny you bring up this case, because I feel like this is often what comes to us too. Is things were going well, things have been going really well, and then we introduced purees, and then once you went to outside of puree, outside of that super smooth can just swallow, things start going haywire. So okay, based on that information, what were the next steps and what were the findings?
Yeah, so I'm thinking about nutrition. So first and foremost, and looking, growth is adequate here, but definitely not in the normal way, given that it's not an age-appropriate diet. But probably the calories are sufficient because we're growing. But given that our diet tends to be predominantly milk, I'm concerned about iron deficiency. There's not a lot of iron in milk. There's a lot of calcium and vitamin D, which is good, but we also need iron. And I'm going to want to transition to some kind of pediatric formula for more complete nutrition. So something that's going to have more vitamins and minerals, but probably also get some labs to see if we have to supplement. As far as the vomiting, it's a weird pattern of vomiting. So the two tests that we often think about are going to be an upper GI series, where you swallow some contrast and it just shows you the anatomy. So I tell parents this is a test to show us the layout of the plumbing. So we're looking for narrowings that shouldn't be there. We're looking for malrotation, which is a congenital kind of abnormal layout of the intestines that can allow them to twist and vomit. And we may also do an endoscopy. Endoscopy is looking at the lining of the plumbing, not the overall layout, but just the lining, looking for any inflammatory issues that could be contributing to vomiting that does not follow the normal infant reflux. So this is a great story for something like eosinophilic esophagitis that may show up in this way. It'd be a little bit young, but we definitely have some young toddlers that show up this way. And if it is eosinophilic esophagitis, the only way we're going to diagnose is through endoscopy, but it becomes a very important thing, because if it is EOE, no amount of feeding therapy is going to make it better.
Nope.
But also, if it is EOE, diagnosis and treating of EOE is going to reduce the inflammation, but there's still a lot of feeding therapy to do to change some of those initial opinions that developed kind of when they were in bad shape. So it's just another great example of how we can't work in silos, because we're only treating a specific aspect of the patient. Certainly, if we do endoscopy and upper GI series, they may be completely unremarkable, which is also often the case. And in that case, that allows somebody like you doing therapy more leeway and confidence, knowing that you're not asking the child to do something they can't do.
Yep. Yeah, that's a big thing that I harp on, is like, I don't know until I know. Right. And I don't want to ever pressure them or put them in a situation where they might possibly be uncomfortable. I want to rule that out and make sure before I push. Because while there is, like you said, if it is EOE, then we get that resolved, we manage it, and then I can push a little more, because I can determine where we're at, and I can think about the psychosocial component of, they probably have some trauma now related to eating, because eating didn't feel good before, and we're going to have to desensitize and work toward that. But the other way also of, if I find out, okay, we don't have EOE, that's great. Why are we vomiting? Okay, maybe it's more of that sensory texture issue. And now we can desensitize more from that standpoint. Yeah, I'm a big advocate for ruling out first, because I don't ever want to be the reason a child went through.
It makes your life easier, I think.
Yep. Agreed. And I think for me, speaking to clinicians, because I get this a lot, how do you refer or get those tests done? Or what are you talking to physicians about? And I honestly just think collaborating and networking, like I just call up and I'm like, hey, I'm Bri, I'm a speech therapist. This is what I do. And just introducing yourself and starting to make those connections within your own community makes for, I think, a lot quicker and more streamlined care. When they understand where you're coming from with things and you understand where they're coming from, you're more likely to meet and provide that collaborative care. Okay. Anything else on that one? Any other thoughts?
Yeah, probably the only other thing to talk about is this is a child who is accepting smooth foods. And that's huge. I think I'm a big fan of smooth foods. Actually, when I was in Wisconsin, the dietitians had made a recipe kind of packet that had about 30 things in there that anybody can blenderize at home. And it was a mix of sweet things and savory things. There was also a recipe for kind of boosted higher calorie whole milk. So once you get to accepting smooth foods, you can make a big dent in formula, because let's say a few ounces of something, I don't know, there was like a taco puree recipe in there, it would have, I don't know, 300 calories or something like that, which would knock out 10 ounces of formula potentially. So yeah, so smooth foods, they're accepting purees. If they're only doing pears and that kind of thing, it's not so helpful. But then we try to push them into kind of some kind of homemade higher calorie stuff that's boosted and allows us to minimize the volume and maximize the growth.
Yeah, definitely. That makes sense. Because as long as we're accepting at least one texture in a variety, then we can really support the nutritional needs. Awesome. Okay. Moving into the second case that you.
Yeah. So this is another kind of typical thing that maybe you see. So this would be a 5-year-old with some type of autism spectrum disorder. Normal growth and advancement of the diet through about 18 months of age, and then started gradually narrowing the diet and going through different food jags where we eat very brand specific, volume specific, situation specific kind of things. Diagnosed with autism at 30 months of age, but probably a mild form. Underweight, very limited diet, and chronic constipation. So also a very kind of typical thing that we see a lot. So when I meet him, he is underweight and he has a poor weight velocity. He might be putting on 1 or 2 grams a day. And once you're below the 3rd percentile, we start thinking of Z-scores. Negative 1.98 on the Z-score, that's the 3rd percentile more or less. So as we go to negative 2.5, I know he's that far below the 3rd percentile. So his diet is Eggo waffles, brand specific French fries, some chicken nuggets. He'll drink some chocolate milk and water. So that's what we have to work with. He's verbal, he's interactive. He doesn't vomit, choke, or gag with his preferred foods. He's potty trained, but he's got stool withholding behaviors, and soiling. Constipation is super common with autistic patients. He's not quite an ABA therapy. He's had some what mom calls sensory feeding therapy and has not made much progress. So that's kind of like where we are.
Yeah, no, that is definitely a classic case that we will be seeing in our clinics as well. And I think I love that the cases you chose are ones that do involve that multidisciplinary care. And sometimes we might see this child and they have never seen a GI before or never seen a dietitian. And we might be the first one to even bring up that, hey, we need to make sure that we're targeting that area as well, because like you said, we're in therapy, there's not much progress being made. And sometimes you have a child who comes in and you might not see any major red flags right away that signal a referral. But if you start therapy and you're not seeing progress, that to me signals, I need to go back to the drawing board. I need to go back into the history and figure out what I missed and where we need to go. Because typically are the strategies you're implementing, as long as you have carryover and regular attendance and all of those things, you should be seeing some progress. And if you're not, then something's missing.
Yeah, something's not right.
Okay, so what are you considering when you think about?
So again, always starting with growth and nutrition, number 1. This is somebody who's not growing well, but he's not vomiting, he's not having diarrhea, he doesn't have a long line of like sickness and seizures and respiratory problems. So more than likely, he just flat out just needs more calories, which probably makes the most sense. He's getting some vitamins and minerals from his Eggo waffles. And we've seen so many cases of somebody that's got a really limited diet, but there's some kind of children's cereal or something in there. Those things are so packed with vitamins and minerals that they can sometimes make a big difference. So that's a good thing. But definitely I want to do some nutrition labs. We always screen for celiac disease. Celiac disease is about 1% of North Americans in general. And nothing that's jumping out at me as saying celiac disease, but we always throw that one in. We always want to sneak in a multivitamin. And however we can sneak it in, there's liquid formulations. You can always crush one of the pediatric complete vitamins. We want to try to boost calories wherever possible. So whatever, if they're accepting chocolate milk, can you add some whipping cream to the chocolate milk? Can you do carnation instant breakfast type stuff? Can you do a formula type stuff? Butter can go in all kinds of stuff, oil, salad dressings, peanut butter, wherever we can sneak calories. And then obviously it's going to be feeding therapy with the goal of chaining from one to the other to gradually expand things and seeing obviously if we can transition some of his drink to a formula, which would be good.
Mm-hmm. Definitely would help with the management of the nutritional intake while working on skill development, while working on that experience.
Yeah. And then on the medical side, he doesn't vomit with his preferred textures. He's doing some chicken nugget, some French fry. It's not vomiting. My concern for something like EOE or acid-related disease is very low in somebody like that. But what I do in these cases, I'll say, I'll keep that in the back of my mind, but let's see what happens with therapy. Yeah. And if you're not making the expected gains, then I'll go back and scope. But this is not somebody that has something that's jumping out in front that makes me want to scope them. Constipation, clearly an issue, like we talked about. Going to use osmotic laxatives, stimulant laxatives, and definitely the toilet sitting scheduled. And that's something ABA therapy can definitely help with. That becomes an important thing. And then we want to boost appetite. So we want to establish some kind of schedule where we're only getting the brain-specific French fries on a schedule and not grazing on them. And definitely we can try cyproheptadine, see if it helps us. But it's, again, a very kind of typical thing that we see at times.
Definitely. And I think this is something more anecdotal, but I have found with autistic children that I see oftentimes their hunger cue tends to be a little bit more suppressed, but I feel like their satiety cue is stronger. And so I often find with those children that they are not coming to you saying they're hungry, but when you do finally get them to sit down, it'll be smaller amounts before. And maybe, I think there's a lot of reasons that's a possibility of they are dealing with constipation. You just feel fuller and ickier faster. And, or if they also have reflux and they want just smaller volumes of foods, but I find that a lot of time, or they're just way more preoccupied with whatever is going on to where the hunger cue is just suppressed. And there's other things that they are hyper focused on or stimming on or whatever it is. Something else I have found beneficial with autistic children is coming up with a mealtime routine even beforehand to start to bring in environmental cues that our body needs to start being hungry. So maybe they wash their hands, they help grab the plates, they help with setting the table or doing certain things in a routine manner that even gets their body ready to cue we're going to be eating, instead of just going from not doing anything to sitting down at a mealtime. I found that to be a little bit helpful in that cueing of minimizing the grazing while you're doing the routines of let's work on that. What else can we do? Because we know autistic children, they have different things that can cue them in. And so what's going on in the environment that might help cue externally, oh, it's going to be a mealtime soon, to prep their body. Anything else to add on to that case before we go into our last one?
No, yeah. I think the only thing I would add is that I think as some of the folks with autism get a little bit older, and especially if they have not had ABA and things of that sort, we may be limited in what we can do. So there have been definitely some cases where we just say, look, we're probably not going to expand the diet.
Yeah.
But we can make sure that you're getting what you need and you're otherwise healthy.
Yeah, and I think that's a great point too, because in some of those situations, like you have this, in this case, you were saying it was a 5-year-old male, but you have an 8-year-old, for example. A lot of times you have to kind of focus in on what is it that will just help alleviate some of the stress the families may be having. Because I've also had cases where the family comes in and they're like, oh, I was sent here by the physician. And I'm like, what are your concerns? They're like, we're not concerned. We don't mind that he's just eating pizza and applesauce. And it's okay. And there's also a level of, okay, nutritionally, let's make sure that your child's getting what they need. But if you're not too worried about it and the family's not gonna go, then that's okay too. They're still growing, they're still thriving.
Yeah. No, and the other thing that comes up that's related to this, in a lot of kids that we see that have developmental delays for whatever reason, development comes in weird spurts and It's not smooth and even. So there are times where they may be making more progress in augmentative communication.
Yep.
And we go, it's fine. It's fine to back off from feeding. We'll stay where we are, but let's put all the energy into augmentative communication. And then we'll come back and hit feeding later when they're more primed to do that.
Yeah.
So, it's going with where strike while the iron's hot.
Yeah. No, that's a great point. And just, I think that goes into following the child's lead and making sure you're reading their cues of, is this something they're ready for? Is it something the family's ready for? And bridging it from there. And I also, in a lot of these cases where the child might not be motivated to expand it. And so if they're not super motivated on expanding certain things and the family isn't too concerned, you're gonna hit a wall there. And as much as we feel certain things should be done, it's not up to us, and the family ultimately on board with whatever is done. Okay, going into the final case here.
Yes, this is also another case that we have from here, basically, theoretically. It's a 2-year-old male. The family immigrated here from the Middle East, recent arrivals, was born at term, but suspected of having an in utero stroke and has hemiplegia and seizures. He's basically feeding on whole milk with carnations and breakfast, maybe about 10 to 12 ounces daily from an infant bottle with occasional choking. Accepting small taste of smooth solids, but has like residue throughout their mouth when they shouldn't. And underweight, BMI for age Z-scores like -4, so we're pretty underweight at this point. No feeding therapy and unsure regarding developmental potential of where we are. So we're starting with something that's a fairly severe medical acute problem, but it's definitely a chronic problem that's severe and has not been addressed yet.
Yeah.
So when we evaluate them, obvious signs of malnutrition, not a lot of subcutaneous fat, has a very low BMI for age. The diet is very limited, drinking milk and with carnations and breakfast from an infant bottle at 2 years of age. Some constipation, has bowel movements every 3 days with a glycerin suppository. No well-defined history of pneumonia, lower respiratory illness, but definitely has wet and noisy, weird breathing with some retractions. And obvious kind of motor delays, has head lag, not yet rolling, not sitting, with preference for the left arm. So that's kind of like where we are. So, whoa, what do we do here?
It's a lot. And I think these are also cases that we come about seeing. Hopefully by the time they are coming to us for therapy, they've already had this medical side managed, because even without reading your notes, I had an idea of where this was going to be going.
Yeah.
This is a child that is very malnourished, and given the complex status of hemiplegia and seizures, if we're not achieving nutritional adequacy, then those things are just going to be exacerbated.
Completely. So thinking about this nutritionally, we're very much underweight, getting some vitamins and minerals with the milk and carnation, but definitely not enough, and we need some kind of pediatric formula in there. But from the medical side, definitely concerned with the medical sort of level of malnutrition, definitely worried about safety, airway protection, and that kind of thing, and constipation is going to be an issue. So this is somebody that we're going to recommend a gastrostomy tube right off the bat. Here, like in most places, gastrostomy tubes can be placed by surgeons with a laparoscopy, where they get a low profile button right off the bat. Or they can be done through what's called a PEG tube, which is an endoscopic procedure that was actually pioneered by a pediatric surgeon that retired in Greenville. I think he worked in Greenville for his last few years.
Oh, that's awesome.
Dr. Ponsky. And the endoscopic procedure has the advantage that it's a very quick procedure. Literally, we can place it in 3 minutes in somebody who's even relatively sick. But the downside is that you do have some tubing that comes out of the body for 3 months until you can swap it out for a low profile button. But in somebody like this child, having some tubing coming out of his abdomen, or a young infant, it's not that big a deal. If you're like a 15-year-old high schooler that needs a gastrostomy tube, yeah, we're going to get you a button right off the bat, because that's better. But definitely need some kind of G-tube here. I need to address constipation. Constipation, we're going to address that with hydration. We also probably need some laxatives. And this is somebody that once we're all tucked in, we probably want some type of swallow study to kind of understand. We do have some kind of neurologic injury here. There's probably much more risk for problems with airway protection and efficiency. And we want to delineate what are the boundaries of what we can do orally to start.
Yeah. Yeah, definitely. And I think that's where I was saying with our role, oftentimes we're coming in right after those things have been established. So they've had the G-tube placed and now it's okay, now what? And that G-tube placement really provides I don't want to say like something to fall back on, but it's that tool that we can use where we now know the child is going to grow and have their medical status managed, so we can work on skill development and we can work on progressing them to something more appropriate and efficient.
Yeah, I mean, one of the ways we've explained this to parents that without the G-tube, you have one pile of calories that has to be in there for growth, for nutrition, for skill development, and for enjoyment, by the way.
Yep.
And if you have a neurologic injury with a significant difficulty in doing this easily or safely, it's going to be a terrible time for everybody involved. But with a G-tube, you now have two separate piles of calories. You have one pile that's strictly for growth and nutrition. That's the G-tube or the NG-tube. And then the other pile is just for skill building, for enjoyment, for positive experiences, where you worry only about quality. You're not concerned about quantity yet. You're focusing on quality, knowing that if you establish that, then the quantity will come a little bit down the road.
Yeah, it definitely allows for being more responsive to what the child's cues are and what they're telling you during meal times, as compared to, like you said, where you only have one pile of calories and you're like, have to get them in. Otherwise,
gotta get in, whether you like it or not.
Yeah. And then that can lead to, unfortunately, force feeding and really stressful meal times. And it's not by the caregiver's fault. It's because they have to.
When I was in Wisconsin, I have one child where we've actually placed a gastrostomy tube because of behavior.
Wow.
You know, she did not have any medical issues or skill issues. Just her feeding was so dysfunctional with her parents.
Yeah. Just
that we actually had to place a gastrostomy to do like a start over.
Wow. Ugh. Yeah. And it can get that severe. And that's a testament to that and how important the psychosocial component is and why that factor is put in there. That is a factor we really have to think about, because mealtimes can be very stressful.
Yeah, absolutely.
Awesome. I thank you so very much for coming on here and talking through all of that with us. Is there anything else you wanted to say or make sure we covered?
No, I just want to make sure I thank my two colleagues here at Duke, Jamie Thompson, speech pathologist, and Sarah Gregory, dietitian. You know, we have a small operation. We're not there every day. Like in Wisconsin, we were there every day with a whole crew of inpatient and outpatient people. Here it's a much smaller kind of outpatient focused kind of operation. Hopefully we can grow it up at some point and bring in psychologists and more intensive kind of options. But for now, I think we're doing okay with what we have, and I certainly couldn't do what I'm doing here without those two.
Yeah, that's awesome. Yeah, team approach is definitely the way to go. Awesome. Well, thank you so much, and I look forward to staying in touch. Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow Bri, me, on Instagram at Pediatric Feeding SLP. Or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.